Thank you very much, dear Chairperson. At the outset, a big thank you to Team RSSDI Gujarat. Special mention of Dr. Akash Singh, Dr. Jetwani sir, my dear friends, Dr. Sushil, Dr. Rutul, of course, our Bansi Sabu sir for this kind invitation. So, dear friends, the last talk of the day, so bear with me, but I'll make this very, very interesting. The topic that has been given to me is how can we use artificial intelligence to improve outcomes in diabetes. In retrospective, what Dr. Jetwani wants to ask me is, bhai itna to AI karte ho, is there really any evidence in it or not? That's what the scientific chairman has asked me this question, and I will try to give you the evidence-based research behind it. So these are my disclosures. Of course, I might be talking about a few proprietorship models, some companies, but I don't mean to endorse them, and they are solely for the purpose of illustration, and a lot of artificial intelligence has definitely gone in making this content for you. So this is the data from the recent 2025 IDF Atlas, where the burden of diabetes has gone up from 583 million to 589 million individuals, with a prevalence of around 9% of pre-diabetes. And I thank Dr. Sunil Gupta sir for setting the context to this session by his talk on pre-diabetes and how lifestyle modification can make an impact. So let's look at some of the unmet needs. And Dr. Gupta sir had mentioned multiple times about the diabetes prevention program, and especially the US DPP program. But from the study, we also find that this kind of programs have been underutilized because it was reached to only 2 to 4% of the population. So what was the problem? Many individuals at higher risks were not identified or not screened because of poor personalization or interventions that led to limited impact. And there were many dropout from these prevention programs. So this kind of unmet need actually indicates that there is a role of digital tools, and especially artificial intelligence, to broaden the access and engagement. Also in type 1 diabetes, we know we need to prevent the complications, but then there is a lot of burden like the glycemic control, and the glycemic variability becomes a big challenge. Delaying in screening and fragmented care because of the diverse population, logistic issues, etc. And then it becomes the diabetes distress and the management burden. Access to technology is not a limiting factor because everybody has the power of a phone, the power of a chatbot, the power of an app through which we can solve a lot of problems. What about hyperglycemia in pregnancy? And of course, Dr. Gupta is here, Rutul is here. They do a lot of work on hyperglycemia in pregnancy, but we still feel that there is a lot of unmet needs in gestational diabetes. Late stage detection through OGTT, delaying crucial interventions. Then we have multiple diagnostic criteria, which often leads to confusions amongst clinicians. High burden on the healthcare system due to complex testing requirements, risk of misdiagnosis and delayed treatment, etc. So these are some of the unmet needs which kind of prevents us from practicing what we preach. Saturdays and Sundays we preach the best standards of care, but Monday we fail to do that because there are some need gaps, and we try to address this need gap. So why does these traditional models fall short? Because in-person models require time, travel, and staffing, which is not feasible for all, and there is a lack of personalization limit impacts across the population, especially in a country like India. So we can have digital solutions and AI solutions that can automate these routine processes, personalize intervention, and scale to reach more patients in the right point of time, thereby reducing the geographic barriers and enabling the proactive management, the right impact at the right point of time. So this prevention window is a very, very important window, and this needs to be tapped with technology and artificial intelligence, thereby reducing that missed screening and metabolic damage which can easily be done, and as a result we can have more cost-effective approaches coming up. So this is where AI and machine learning can come in to fill this need gap in diabetes care. But now the question you will ask me is, okay, we understand there is a possibility, but does the evidence show that digitalization and AI can solve some of these challenges? Let's take a look. First, on digitalization, this is again a paper that has been published from the DPP program, which sir also showed that 5% weight loss using a digital prevention program. And these digital diabetes prevention program had showed similar HbA1c improvement to in-person formats. Going forward, there is another paper which is a systematic review, and this also showed 56% of the RCT showed benefit in this systematic review. And it showed, and this kind of benefit has been seen across both computer-based and mobile formats. But long-term diabetes incidence reduction is yet to be proven with digital diabetology technique. Going forward, we also have text messaging platforms with SMS feasibility, which are easy to use, simple to offer to the patient, not very costly. These can bring in clinical benefits with a global scalability. That is very important. But also from our COVID days, we have learned that just not technology, we need to have a hybrid approach. So in-person plus online mode of engagement with the individual. It does come with challenges like message fatigue, low interactivity, or even uneven results. But all that taken into point, the more research we have, the more we will understand this technology. Now, why artificial intelligence? This is the question of the day. Why are we talking about artificial intelligence? Take a look at this. All our research, all our studies, our trials, our real-world evidence is just the tip of the iceberg that you see. The case control study, the RCTs. We are missing out on the whole of the iceberg, which can be tapped in from the data of the patient. And this means the image data, the text data, the nutrition-based data, the research data, their lab data from the electronic health record. And that would give us a lot of more information to work on the research. So we see a paradigm shift happening in the research methodology itself with the data, information, and intelligence coming into existence. So we are practicing evidence-based diabetology, but with artificial intelligence and technology, possibly for the first time in the history of medicine, we are going to be evolving into the era of data-driven, intelligence-based precision diabetology. And thereby we will be able to cover the whole of the iceberg, possibly addressing those unmet needs. So how can we use AI to improve our outcome in diabetes care? These are the 6 blocks in which we can improve. In disease prediction and risk stratification, in self-management using generative AI chatbots, in insulin pumps and the continuous glucose monitoring system, which are already existent, in screening for diabetic retinopathy and diabetic foot complications, and of course, the most important need of the hour is in clinical decision support system. Let's explore one by one. Now we know that there are machine learning models which uses various supervised learning techniques, which has been found to outperform the traditional risk scoring methodology. So you can have risks prediction using machine learning, which has got fantastic accuracy, and the data for this would be, the resource would be from the electronic health records, the labs, and the demographic data of the individuals. This would allow a geographic-based model, a multi-ethnic model, or even a loco-regional model or a hospital-based model to evolve. This exists, and take a look at this study from China, which has used machine learning method to predict the risk of pre-diabetes using a nationwide cross-sectional data survey. And this is an example where if you have the data, you can tap into the data to get you certain kind of a prediction coming out of the data. Similar to type 2 diabetes prediction or other types of diabetes predictions, we can also have diabetes prediction of hyperglycemia and pregnancy. And this is a paper that looks at explainable AI-driven gestational diabetes mellitus prediction using clinical and laboratory markers. And this again used explainable machine learning tools, and they used AI analytics to give a predictive algorithm for detection of hyperglycemia in pregnancy. This is another AI-driven prediction of gestational diabetes. This was done in Mexico, the Mido AI model. And this used easily obtainable variables for GDM predictions, and it achieved 83% sensitivity. And it is typically designed for resource-constrained environments to enhance early detection. We are talking about primordial prevention of gestational diabetes. Possibly machine learning and artificial intelligence has a way of showing us the way in achieving that. Why diabetes care needs generative AI? Now we are all fascinated with GPT, ChatGPT, Perplexity, which utilizes generative AI, because we know there are 2 limiting factors. The glycemic variability is a big challenge, and the psychological burden and the diabetes distress in the individual. So you could have the utility of generative AI to predict the glucose trends, provide personalized care, and support the patient in self-management through AI-driven education. And this is something that we are going to be exploring. And this can be achieved with the help of something called AI agents, which is the thing of 2025 in the field of artificial intelligence. So the problem we know is that one size does not fit all. The solution is possibly with the help of natural language processing. Now, what is NLP or natural language processing? It's a subfield of AI that focuses on the interaction between computers and humans. In simplification, you speak to the computer in your language, the computer codes it, but replies back to you in your language. That's what NLP is. With the help of AI, with the help of ML, with the help of NLP, we will possibly be able to achieve enhanced patient adherence and better glycemic outcome and address those unmet needs that we keep talking about. So we can have AI for diabetes education, for personalized learning experience with the help of chatbots and virtual assistant, and you can even reward the patient with AI-assisted gamification, which has also got a lot of science behind it. This is evolved from the concept of just-in-time adaptive intervention, which means that if you can impact the patient with the right information at the right point of time, then you're going to be bringing in the maximum behavioral impact in the patient's approach to the disease or clinical outcome. And this is what we need to tap using AI and machine learning. This was a paper we published in 2023 in the International Journal of Diabetes Technology. And this speaks about how we can actually use a generative AI model like ChatGPT or anything else for that matter for improving diabetes care with various applications. The QR code on the left gives you access to this free access paper. Please read it at your convenience. We worked further and we have come up with something called Madhu AI. So it's a research bot. It's in the research level. It's a chatbot that integrates generative AI in the WhatsApp user interface. And it is a patient education platform and a knowledge resource platform. We went further in trying to evaluate the safety and the efficacy of a tool like Madhu AI, and this research was recently shared in the ATTD at Amsterdam. It's an unpublished data, but it did go on to show good score in terms of accuracy and relevance, neutrality and negating bias, and providing an overall empathetic helpful care to the patient with the right knowledge at the right point of time. Let's go into the other spectrum, screening for diabetic retinopathy. Now we know that AI-based screening exists, but why is it so successful is because the other traditional methods of retinopathy screening has been found out to be a lot of limitations, with the traditional referring happening only in 22% of completion, whereas AI-based screening having 100% completions. Such that FDA in the year 2018 gave approval to IDX Topcon fundus camera as the first approved AI-enabled camera for diabetic retinopathy screening. Take a look at this paper published in Nature. We conducted a community-based survey in Chandni Chowk area in Kolkata with an AI-based camera, and we found that the prevalence of diabetic retinopathy in the community was 13.7%. And hence, these are the need gaps that artificial intelligence can help us to address. We can also find the use of AI, smartphone-based camera for screening of diabetic foot complication using thermal imaging. And we know the RSSDI, we have so much of data sets from Save the Foot campaign. Probably we could use something like this to build a predictive algorithm for detection of diabetic foot complications. This will enable remote monitoring and screening, and especially it would be very well suited for low middle income group countries like India. This was one of our paper we published sometime back in the DRCP, and this looked at an overview of how AI can actually impact diabetic foot complication screening and prevention. What about continuous glucose monitoring system? Now we know the CGMs screens for 14 days, but you have a research that tells you that even beyond your 14 days, an AI-driven algorithm can give prediction for another 14 days, and this has shown to improve the time in range by more than 7% than the baseline versus the standard CGM which exists. And this is the publication of January AI, which is US FDA approved, and it's available in the US. Have we closed the loop with artificial intelligence? These three diagrams, A, B, and C, gives you an idea of what happens in the back end of an AI, of an insulin pump. But now, as we evolve with artificial intelligence, there is a layer of machine learning that can be added. And here you will see over and above the conventional PID and the MPC algorithms which are existent in these insulin pumps, machine learning will be able to augment the performance and more precision glycemic control in the individuals who are on the pumps. One such example is the bionic pancreas pump, the beta bionic pancreas, and this is the result which has been published in NEJM, and the RCT shows 0.5% HbA1c improvement versus standard therapy with the AI-enabled insulin pump. Telehealth and remote monitoring is something that we have used and we are using in diabetes practice, and COVID-19 times have definitely showed us that there is a lot of potential in using it, but in a hybrid mode combined with in-patient visit and physical consultations. It takes away a lot of geographic barriers away, reduces the travel cost, and this enabled with AI, with the chatbot, with the right information to the right patient at the right point of time, using AI-enabled guidelines can kind of do wonders in addressing the need gaps that we talk about. We will be looking forward to have clinical decision support system, not to replace a clinician, but to augment the performance of a clinician. And this is where the systems are going to be integrated with the pump, the CGMS, and the EHR of the doctor. And something like this already exists, and it is FDA approved. DriaMed, it's been made in Israel, and it's approved in the US for treatment of type 1 and type 2 diabetes. And this is the world's first AI-enabled clinical decision support system, which is approved by the FDA. Going forward, we will see the application of AI in digital twinning, in multi-omics integration, especially in nutrition, personalized nutrition, and in precision application, even in precision pharmacotherapy, as we speak about it with AlphaFold and all the other fields evolving. But there's going to be a lot of challenges as we go forward. And the first challenge will be to integrate with the workflow. Adoption is going to be the key. And at the moment, we don't have data interoperability, so that's going to be a big challenge. Financial sustainability is at the moment the biggest challenge to any tech entrepreneurs. Alert fatigue to the patient as well as to the doctors when they're connected. And most important challenge, what we are facing right now is real-world validation. You have tools, but they're not validated, they're not evaluated before they're released into the market, and this is where medical professionals need to get literate and come in. There's going to be a lot of biases coming in, and biases would largely depend upon the data source, so we need to find out strategies to mitigate these biases as we go along. There's going to be questions being asked about data privacy and data governance. We are still very gray in that. The DPDP Act, the GDPR, the EU AI Act gives us some idea, but I'm sure as we evolve with the data to information to intelligence, these regulations are going to get more and more streamlined, and it's going to be structuring the way we will be using our patients' data. At any given point of time with AI, we need human oversight because there needs to be explainability. And most importantly, the clinician, the human in the loop, has to have the final authority, and decision must remain clinician-driven in the best interest of the patient. Equity and digital divide is going to always be another challenge towards making it equitably distributed across the spectrum. Regulatory frameworks will evolve with risk-based approach, and validation requirement is the need of the hour. So from organizations like the International Diabetes Federation or the RSSDI, these are the three segments where we can work as clinicians in evolving the standards of these tools, validating these tools, and bringing out the ethical principles on how these tools should be explainably used in clinical practice. These are some of the existent regulators across the globe: the HIPAA, the GDPR, the FDA, the EU Act, and in India we also have the DPDP Act, which is quite good, but it still needs to evolve as we go along. Scaling will be a big challenge, especially in low and middle income countries, but at the same time, we must remember that the true essence of technology and AI can only be utilized if it's available, affordable, and accessible to one and all, both the patient and the doctor. And as clinicians, keeping the patient in the center of the treatment, we must all strive to do this. Training of the clinical workforce will be the next challenge, and this is why we have the IDF, the RSSDA, and of course the ICAIM, which I will introduce to all of you, which will be working towards making the clinical workforce literate on digital tools and artificial intelligence. So I'll leave you all with this question that there is a lot of evidence that AI can make a change in diabetes care. But the question that we need to ask ourselves is, are we ready to adopt this change in diabetes care? Allow me to introduce you to Arti, a small robot. This is drawn by my daughter as she keeps on fascinated about the application of AI. Going forward, I would like to introduce you to one wing of Doctors AI, which is the Indian College of Artificial Intelligence in Medicine. Some of you are familiar with it, but going forward, we will definitely bring in more activity for the medical professionals. This is one textbook that we have launched, and if you would like to get a copy of it, you could just scan the QR code and kind of order it from the JP publishers. And also, we have a structured certificate course of artificial intelligence in medicine. The second batch starts in June. Anybody who wants to get their hands deep into AI and deployment of tools can join this course. This is the last slide, and I'll leave you all with this thought that these technologies are there to stay. They're reshaping diabetes care. As clinicians, we have to be informed, proactive, and ethical in adoptions. Researchers will have to bring in more real-world validations, as well as us. Policymakers will need to enable equitable scaling of digital tools to make them sustainable. Only then we can move towards precision diabetes care. Thank you very much.